Dr. Janani?
Got it.
So, good evening, ladies and gentlemen.
Yes, sir.
Back again with our grand rounds from the dawn, Professor Anthony. And last week, we saw a grand rounds on CA larynx. And Dr. Janani finished with the diagnosis. And today, we're going to see the management of CA larynx. I saw every bit of it. And I was like, bewildered to listen to the questions which Dr. Anthony was asking about CA larynx. So in-depth examination of this case. I'm sure that all the PGs will benefit by this grand rounds for sure. And don't miss it. If you want to go to the exam, see this and go. So without much ado, over to Professor Anthony. And all the best, Dr. Janani.
It's a great pleasure in watching Johnny Ram operating, talking, and introducing. Without much this thing, all the best, Johnny, and you can go to the case, right? Then yesterday we saw up to the X-ray chest, right? X-ray chest. Then what are all the other investigations you do for your patient?
So they ask for a contrast enhanced computer tomography of the neck from skull base to medial sternum with the
They are not audible.
hello, sir.
Yes, it's better.
Sir, we ordered for a computer enhanced contrast enhanced computer tomography of the neck from the skull base to the medial sternum. 3 mm cuts in mild in a normal breath. If required, we can ask for we usually ask the patient to have a normal breath while the CCT is taken. And if we are planning to see the piriform apex region, we can ask the patient to take a deep breath. So in this case, I would like to start with a CCT neck, sir.
Okay. What are the advantages of CT scan neck? What are all things we will look at?
Sir, CCT neck, the major advantage is that we can see the pre-epiglottic and paraglottic space involvement, the anterior commissure involvement, and the involvement of the thyroid cartilage. And the relationship, this means that we can, by using radiology, we can either the tumor can be upstaged. The relationship of the tumor with the ventricle can also be studied with a CCT. The tracheal position, the lymph node status, and the pretracheal, paratracheal lymph node status can be assessed with the help of a CCT because it has got a good sensitivity, 74%.
Janani, when you are presenting in an exam, you answer like this. Examiner will go to the next question. But for grand rounds, you got to go step by step, right? So when you take a CECT, what are all things you will see is, you see the first thing you should see is the tumor volume. Why tumor volume is important?
It will determine the plan of management, sir.
The large volume tumors may not be amenable for radiotherapy. So you got to be, I mean, that's not the only criteria, but you should also keep that in your mind. You see the volume of the tumor. What is the critical volume?
5 centimeter square is the when the tumor is less than 5 centimeter square, it is curable. When if it is more than that, it becomes a palliative.
Curable by the radiotherapy. Okay, curable by radiotherapy. If it is more than 4 centimeter square or 5 centimeter square, you got to think of gold standard treatment. Okay, that is the first one. Second one is you got to look the tumor involvement of the anterior commissure. Why anterior commissure is important?
If anterior commissure is involved, it means that the tumor has a high propensity to invade the thyroid cartilage, and inner perichondrium, we cannot clinically see in the involvement of thyroid cartilage unless it invades the outer perichondrium and becomes an extralaryngeal tumor. So the invasion of inner perichondrium of thyroid cartilage can be assessed with by seeing anterior commissure involved.
Similarly, the anterior commissure is an area which is very close to the supraglottis and the subglottis. Okay, so an anterior commissure involved tumor can easily go to the supraglottis or the subglottis. What are all the hidden areas in the direct laryngoscopy? Hidden area in the indirect laryngoscopy or a visualscopy in larynx.
The hidden areas are tubercle of epiglottis, the anterior commissure,
Petiole of the epiglottis,
petiole of epiglottis, the anterior commissure, the ventricle, the under surface of glottis, and the subglottis.
Subglottis. So all these areas can be seen better, particularly when an anterior commissure is involved. You can see whether petiole of epiglottis is involved or not. What is the importance of involvement of petiole of epiglottis, which you cannot see by indirect laryngoscopic examination?
It means that the tumor has become a supraglottic spread has occurred.
No, the supraglottic spread can occur at the ventricle. Why it is important on the petiole of the epiglottis? Infra-aortic part of the petiole of epiglottis. The infra-aortic part of the petiole of the epiglottis has got a lot of pores. So, epiglottis tumor can become, when it involves the petiole of epiglottis, the chances for it to go into the pre-epiglottic space is better. Okay, so you got to assess whenever you see the petiole of epiglottis is involved, you got to assess the pre-epiglottic space. Similarly, if it goes down, if the anterior commissure is involved, you should give special attention to the subglottic extension and then under surface of the vocal cord. Okay, but what is the drawback of CT scan?
The major drawback is the nodal status cannot be the cartilage.
In the larynx.
The cartilage, the erosion of cartilage only
in the patient has got a T1. The patient has got T1 involvement. Will you take CT scan?
No, sir. Direct laryngoscopy is better.
So, whenever the patient has got a small involvement, for example, small subglottic involvement, small involvement on the ventricle, or a small involvement on the petiole of epiglottis. Otherwise, early tumors cannot be diagnosed or confidently diagnosed with the imaging, particularly CT scan. So, whenever you think of doing the CT scan for a small involvement, it's always safer to do a direct visualization than the doing CT scan. Okay, then so you look for cartilage invasion, look for extralaryngeal spread. Okay, cartilage invasion will upstage the disease from T3 to T4. So that is T4A. So that is very important. Then what else you will look in the neck? Why paraglottic and pre-epiglottic, paraglottic and paratracheal and pretracheal nodes are all important.
Sir, if paratracheal pretracheal node is involved, the neck dissection will become radical, and it can become a radical, or we have to include.
What happens when you do a total laryngectomy, leaving behind this node if you are not aware of?
It has higher chance of becoming a recurrent, and stomal recurrence can occur.
So, cause for stomal recurrence is the leaving behind paratracheal node and the pretracheal node. So, mentally, you will be just prepared to do a central compartment dissection and searching for these nodes when you know these nodes are all involved in the CT scan. Okay, what is the other common nodes involved in the neck?
Delphian nodes, the prelaryngeal nodes can also be involved.
Okay, then on the lateral neck, what level nodes are all common?
If it is a glottic tumor, level 2 and 4 is involved more commonly. If it is subglottis, also level 2 and 4 is commonly seen. Supraglottic tumor will mainly level 2 and 3.
Subglottic tumor, what other node is important? If it is?
Retropharyngeal.
You take up to the level of mediastinum. Why?
Anterior mediastinal group of nodes can also be involved.
So whenever there's a subglottic involvement is there, you should look for tracheal involvement and the level 6 and level 7 nodes. Okay. So these are how do you identify node on a CT scan?
If it is a malignant node, it becomes the size shape should be first examined. Following that, we'll see the extranodal invasion of the extranodal invasion, and central necrosis will be there, and the node becomes elliptic, spherical in shape, and central micro calcification can be seen if it is a metastatic node. Loss of fat.
The indentation on the capsule of the node, it's not smooth, but it will become bumpy, and there's a central halo will be there. So these are all the common features of the nodal metastasis. Okay, then fine. What other imaging you will do? If you are not, when a patient has got a calcified thyroid cartilage, so CT scan will not detect tumor invasion very easily. Then what other investigations we can do?
Then we have to go for an MRI next. T1, T2. In T1, we can since the fat in T1 will be seen as a hyperintense, and in T2 will be seen as a isointense. But if it is involving the cartilage invasion is seen, since the cortex is hyperintense and the cortex is hypointense in both T1 and T2, but medulla is hyperintense in T1 and hypo or intermediate intensity in T2, which means that if the cartilage erosion is there, it in early stages like inflammation or minor osteolysis can be seen in an MRI better.
What are the investigations you
Uh,
do? See, MRI is very useful to see the loco-regional spread. Okay. What other investigation you use for spread?
we can do a PET-CT, sir.
PET-CT is for
Metastatic workup and loco-regional.
Second primary.
Second primary.
Okay. So for a metastatic workup and second primary, PET-CT is better investigation. So you need not do the PET investigation for all cases. For example, there's a tumor which is T2 tumor, T1 tumor. You don't do the PET-CT because it's very, very unlikely that it will have gone for metastasis. But a patient who has got a subglottic extension, the patient who has got a larger tumor, larger volume tumor, where there's a chances for second primary is high, those tumors you got to do a PET-CT. Okay, then you have done all these investigations. Including last time we have seen about the fees, and you have seen about the penetration and aspiration in the contrast piece of diagram. Okay, then what else you do?
Then we can go for a direct laryngoscopy mediated biopsy, sir.
Okay, what anesthesia you do the direct laryngoscopy?
General anesthesia with orotracheal intubation.
Okay, nasotracheal or orotracheal intubation. Then what are all things you will see in direct laryngoscopy examination?
We can map the tumor, sir, and we can see the extent of the tumor, the surrounding soft tissue the surrounding involvement of other areas, and we can do the probe test, and also we can look for with the help
probe test.
If sir, in this case, cricoretinal joint fixity is
why is it important?
It means that subglottic spread is has occurred. Hemilarynx fixity is there, so subglottic spread is there.
Then
And then we can look for, with angle scope, we can see for the subglottic involvement. And
with the tube, can you see that subglottic area?
we can see, sir, but in lower surface of the inferior surface of glottis and subglottis is better visualized with a 120-degree scope.
180-degree?
Angle scope, sir. Any angle scope.
How the scope will go inside?
We can mount it on a. Sir, I don't know.
You got to take out the tube, put the scope inside. What are all the things of your area of interest when you look with an angle scope?
With an angle scope, we can see the infrahyoid part of the epiglottis, the anterior commissure, the base of the undersurface of the glottis, the ventricle, and the subglottis.
So all these areas seem better with the angle scopes. Okay, you can use it 90-degree, 120-degree, or 70-degree scope, thinner scopes to go inside and see that undersurface of the vocal cord and then anterior commissure. So whenever there is a anterior commissure involvement with the subglottic extension, it is better visualized with the scope examination than the thing. Then what did you do? You have seen all the tumor, you have mapped the tumor. What do you do next?
We'll take a biopsy, sir.
Biopsy. Where do you take that biopsy from?
The most
area close to the normal area. Take a biopsy from very close to that normal area, so that in your biopsy there may be an area of normal tissue and then that's an area of the malignant tissue, so that you can see that malignant transformation and you can see clear-cut malignancy. So actively glowing areas will be on the edges. So you take it from the edges. So what do you do with that biopsy?
We'll look for the differentiation of the tumor, sir, whether it is a well differentiated or a poorly differentiated tumor.
Straight away differentiated? Won't you see whether it's a benign or malignant disease?
First, we'll see whether it's a benign or malignant disease, because the plan of surgical management varies. And then we'll go for the.
Not only the plan, you cannot give certain treatments. For example, there's no need to give a chemotherapy or radiotherapy for a benign tumors. Then what do you see?
Then the.
What type of malignancy it is? Okay. What is the commonest malignancy in a glottic area?
Cell carcinoma is the commonest.
95% is squamous cell carcinoma. Why you want to see it's only 95% squamous cell carcinoma? Why you want to see what type of malignancy it is?
Other tumors, we cannot go for RT radiotherapy.
So different tumor, different histology of the tumor will give you different management protocol. So if it's a squamous cell carcinoma, what else you look for? If it's a squamous cell carcinoma, what else you look for?
Keratin.
You told that first. Differentiation.
Well, differentiation.
What is the differentiation classification is called?
Broadest classification is divides whether it is a well differentiated, moderately, or a poorly differentiated or undifferentiated carcinoma.
When you call it well differentiated?
When
it has got more than 75% of the differentiated cells, it's called well differentiated. 50 to 75 is moderately differentiated. 25 to 50% of differentiated cells alone is called poorly differentiated. Less than 25% of differentiated cells, then you call it as a undifferentiated or anaplastic carcinoma. Why is this important?
Differentiation, well differentiated tumors have got a better prognostic survival.
Same size of tumor, same spread tumor, when it is undifferentiated or when it is poorly differentiated, has got a poorer prognosis than that of the well differentiated tumor. So for a differentiation is important as a prognostic factor. Okay, what other things are all important for the prognostic factors?
The tumor size, sir.
In a biopsy. What other invasions are important? Perineural invasion.
Lymphovascular invasion.
angio infiltration. So these things are all you should look for. So these are all got the prognostic values. If the lymphangial infiltration, or there is a cartilage invasion, or there is a perineural spread, you should treat the patient aggressively. Okay. So then, so with all these things, what are you going to offer to the patient?
Sir, for this patient, we can do total laryngectomy with modified radical neck dissection on the right side.
Okay. What are all the indications for total laryngectomy?
The indications can be squamous cell indications, which are either squamous cell, non-squamous cell. Squamous cell indications, which are indications for surgery, and contraindications for RT. Indications of surgery would be tumors which are T4 or more than 5 centimeter. And contraindications for RT would be tumors which involve erosion of the cartilage erosion or invasion. And non-squamous cell indications like other malignant.
Radio recurrent growth, residual growth.
Yes, sir.
Radio recurrent growth, residual growth, and tumor which is in the non-amenable areas like a subglottic tumors. Subglottic tumors. All these things is not amenable for radiotherapy, right? Then in continuity dissection. What is in continuity dissection?
Like in hypopharyngeal malignancies, there is a submucous.
Hypopharyngeal malignancy, it's a base of tongue malignancy. You want to, along with that, you want to do a total laryngectomy. Then you got to do the total laryngectomy. Okay. In this patient, if I say I will do a chemotherapy, organ preservation, what will be your opinion?
Sir, the patient has got anterior commissural involvement, which means that, and the patient has the thyroid.
No, it's only T3. T3 tumor, you can do chemotherapy, right? Why not?
With respect to this patient, sir.
What will you do for the neck then?
If chemotherapy is a plan of management, we can include the field neck in along with radiation.
Which is the best option for the neck metastasis?
Surgery is the best.
Surgery is the best. So you are going to do, best option is surgery. So even though when you plan a non-surgical management for the primary tumor, keeping in that mind that node management is better with that surgery, I prefer to do only surgery for this patient. Okay. So other indications are non-squamous indications, like that's what, when you are doing a radical neck dissection for this patient, along with that you can do the total laryngectomy itself. Okay. Can you preserve the laryngeal function in this patient by giving some other not doing total laryngectomy? Can you do an organ preservation for this patient?
In this patient, organ preservation like supracricoid partial laryngectomy with cricohyoid of X is possible, sir, but involvement of interarachnoid,
It's not involved. It's not involved. Even arachnoid is not involved.
sir,
You can do a TLM, you can do this, you can do an organ preservation, chemotherapy, all these are all options. But most important thing is, two other things are all important. One is the patient factors, like how far the patient lives from the lives from your center, and how much the center is qualified in doing all these things. Okay, sophisticated surgery or sophisticated chemotherapy, which your expertise is there. So that you will do. So if you keep all these things in your mind, you decide what you want to do. And because it is given in the book that I want to do this, I want to do that, it is not possible to do this when you are not experienced. For example, if you have not done supracricoid surgery, or if you are not had enough experience on the near total laryngectomy, you can straight away do the total laryngectomy and neck dissection. Okay, so for this discussion, we'll keep this only for the total laryngectomy and neck dissection. Once we have finished the discussion, we'll go for other options, right? So what are all the other indications, non-squamous indications?
Non-squamous indications like other types of malignancies like sarcomas and chondrosarcoma, and benign lesions like extensive chondromas and
Extensive chondromas, removing everything will be the larynx, which will be non-functional. Then.
and salvage surgery in case of in case where post RT recurrence is there.
That we have already told, no, radio recurrent residual tumors.
Yes, sir.
Then extensive amyloidosis.
Extensive amyloidosis and
Chronic aspirations, which is not amenable for any other modality of treatment. Okay, or the cases of grossly involved road traffic accidents where there is a grossly involved road traffic accidents with a soiled wound. You can't manage or you cannot reconstruct the larynx. Those cases you can do the total laryngectomy. Okay.
yes,
Right.
sir.
Then these are all the indications for total laryngectomy. Okay. How do you classify what incision you will do for total laryngectomy?
So we can opt for the Themistocles Gluck-Sorensen incision, which starts from the mastoid tip, anteriorly curves over the anterior angle of mandible and with 2 to 3 centimeter above at the level of Hawaii, 2 to 3 centimeter above the suprasternal notch, and similarly crosses over the anterior border of sternocleidomastoid to touch the mastoid tip of the other end. If the previous tracheostomy stoma is there, we can include this in the stoma. The other options of since we are planning for a neck dissection, we can use this. We can extend this for a neck dissection.
How do you classify incisions of the neck?
The incisions of the neck are the McAfee incision, which is a in which the McAfee incision, which involves a bipedical.
No, I'm not asking for neck dissection alone. Surgeries of the neck.
Transverse incision and vertical incision, sir. Vertical incision.
Single line incisions, double line incisions, tri-radiate incisions, 4-line incisions, and unconventional incisions. Unconventional incisions like hockey stick incision, U incisions, Gluck-Sorensen, they're all not come into these descriptions. Okay. Single line incisions are skin crease incisions. Or those days they do to laryngectomy midline vertical incision. It's called Jackson's incision. Or you get a single line incision like a skin crease incision. Even today, you do a total laryngectomy, you do a broad-based skin crease incision. You can do a total laryngectomy. Okay. Other incisions are if you do a neck dissection, you do a 2 incisions. It's called McPhee's incision. Okay, McPhee incision. That then tri-radiate incisions. Classical radical neck dissection is done with an incision called Kreil's incision. This Kreil's incision is the an incision along the there's a visor flap with a vertical limb with a small s. That is called Kreil's incision. There are various modifications of Kreil's incision. Few modifications maybe it may be Schaubinger, it may be Conley, it may be Y-shaped incision, it's a T-shaped incision. All these are all various modifications. And then other tri-radiate incision is instead of putting a visor flap and a limb down, you put a T. And then you put an horizontal T, one vertical incision and then one horizontal incision. So you can have a T, maybe a vertical T or an horizontal T. These are all various modifications of a tri-radiate incision. Then you have a 4-line incision. That's called Hayes Martin. The 4-line incision may be an H-shaped incision from the front, or it can be unilateral edge. The edge can be a vertical edge or an horizontal edge. You do a 2 incisions, one along the there is an area called watershed area. The neck blood supply comes from above, below, and posteriorly. So from above, it comes from the arteries of the facial artery and the post-auricular artery. From below, from the transverse cervical trunk, and posteriorly from the occipital and post-auricular arteries. So the area of these, the blood supply above will be up to the level of the iliac bone. You've got a better blood supply. Similarly, up to the level of the omohyoid muscle, you have a better blood supply. In between area gets supplied from posteriorly. Okay, so your line should be in any one of these areas. Okay, so you can put a incision just below the angle, 2 centimeter below the angle of the mandible, like how you put for a, it's called a sort of visor flap from this mastoid to the symphysis mentis, 2 centimeter, 2 fingertips below the angle of the mandible, you make one incision. And similarly, another incision from the close to that clavicle 2 centimeter above, and connect these two. This is called vertical edge. Similarly, if you make one incision here, one incision here, you can connect it horizontally. It's called a horizontal edge. Okay, so these are all the various incisions you use for neck surgeries. Okay, so how do you do total laryngectomy? You forget about neck dissection. How do you do total laryngectomy?
So we plan the skin incision. In this case, we'll use the Glucksorensen incision, and then the sublatissimal flap elevation is done until the submandibular gland, because in this case we are going to include submandibular gland in our neck dissection, and then we'll start with infrahyoid delineation of the infrahyoid strap muscles. This is done as close to the sternum as possible, because it will produce a very beautiful horizontally enlarged stoma, so that it won't go for stenosis in later stage. And then we'll go for
Which is the first muscle you identify?
strap muscles.
Which strap muscle?
Sternohyoid.
Janani, you have assisted me 2-3 weeks back, total laryngectomy. Omohyoid is the first muscle you identify. Okay, identify the omohyoid and dissect the omohyoid. Then you dissect the sternohyoid and sternothyroid. Okay, then what do you do next?
Then we'll, if we can, in this case, we are planning for a hemithyroidectomy. So we'll devasculate.
We said you will preserve to do an hemithyroidectomy.
We'll preserve the opposite side, sir. Left side thyroid.
Okay. What are all the vessels of thyroid you will ligate on both sides?
In the right side, the superior inferior thyroid artery and along with the veins, and the anterior thyroid vein is ligated. In the superior middle thyroid vein, the superior inferior thyroid veins are veins along with the arteries are ligated. The superior laryngeal artery is sacrificed on the right side. In the left side, to preserve the vasculature of the parathyroid and the left side thyroid, will not ligate superior laryngeal vessels, but we can sacrifice the superior thyroid arteries.
Is that you keep the lobe based on the inferior thyroid artery and the inferior thyroid vein, strip it lower down and keep it separately. Okay. Then what will you do?
Then we can. This is when the thyropharyngeus muscle can be cut along the anterior border of the thyroid cartilage, and then we'll go for the
border of thyroid cartilage.
Sir?
Which border of thyroid cartilage? Posterior border of the thyroid cartilage. Okay, when you rotate the thyroid cartilage over the posterior border, you see the thyropharyngeus muscle comes and gets attached to the oblique line. So you dissect it at that area so that you can enter into the pyriform fossa. Okay, so free the posterior border of the thyroid cartilage on both sides. Okay, then what will you do?
Then we see thyroid membrane, the superior laryngeal vessels coming out of the thyroid membrane.
The thyroid membrane.
Yes, sir. Here's the thyroid membrane, and then we'll go for the de-skeletonization of the suprahyoid muscles. We'll release the geniohyoid and mylohyoid can be released, and whereas the hyoglossus should be done. This can be released from the greater horn. Hyoglossus is released from the lesser horn. And along with this, at this stage, the hyoid bone can be it becomes free of the muscular attachments. The greater cornu of this should be done like with a lingual entry, and should be when the hyoid is sacrificed, it should be the cutting should be as close to the bone as possible, like hugging the bone. So After this, we can go for the entry into the larynx. The laryngeal entry can be either on the like either a transvalvular entry or the contralateral.
What will you do?
Yes.
What will you do? In this patient, what entry you will do?
We go for a transvalvular entry, sir. Contralateral entry is reserved for supraglottic tumors. So after transvalvular entry, we'll see the pharyngo epiglottic fold, and then we'll lift the epiglottis with an analyst, and then we'll at this stage we can look for any obvious submucosal bulge, and the extent of the tumor can also be visualized. And we can proceed by cutting by making vertical cuts along the paraglottic space, and the vertical
The
cuts
epiglottis along the area epiglottic fold goes to the
until the
post-cricoid
arytenoid
area.
area. Arytenoid should be lifted to see the post-cricoid area. The post-cricoid musculature should be released in a horizontal fashion, and we should be careful that the posterior, the horizontal incision does.
Separate larynx from the cricopharynx and trachea from the esophagus. Fashion the tracheostome and remove the larynx. Okay, then what will you do?
At this stage we have the larynx has already been delivered, so we'll plan for a cricopharyngeal myotomy and new pharyngeal reconstruction. Cricopharyngeal myotomy is done by like to put your one finger, your glove into like behind the cricopharyngeal musculature, and we release it we tease the cricopharyngeal muscle by a 15 blade, and until the submucosal vessels are seen. Once this is done on the ipsilateral side. After a cricopharyngeal myotomy, the neopharynx reconstruction can be planned. At least 3 centimeters of the mucosa should be there for a well formed neopharynx. This can be closed by a box suture, like or
What is the name of the suture? Canal suture.
Canal suture or a box suture. The thiopharyngeus is placed over this, and a canal suture is taken in first.
How many layers you close the pharynx? How many layers you close the pharyngeal mucosa?
2 layers suture, sir. One should be outside, one should go in, and other it should come out again. So in this way, it forms what is like it is like a tunnel or
Inverted sutures. Okay, inverted sutures for the submucosa. You should not include the mucosa, and then close the serosa by submucous sutures, or close the serosa by continuous or intermittent, preferably continuous sutures. Then what will you do?
Then we'll plan for if we are planning for a primary TEP, so we have to at this stage we decide whether
Primary TEP should have done before you do a pharyngostome closure. Okay, so over that you put the skin flap, keep the drains. How many drains will keep?
Keep 2 drains on bilateral. One drain.
When will you take out the drains?
So drain can be taken out after post-op day. Like it depends more on the amount of drain than the post-op day. So if it is say after post-op day 7, if the drain is less than 15 ml on one side, or it's a serious the drain content is very serious, then we can plan for 1 drain removal. The next day, if the amount of drain is less than 20 ml in 24 hours or less than 12 ml in 8 hours, we can remove the other drain also.
Okay. When will you remove the skin sutures? How will you make a tracheostome? What is the name of the suture is called?
You can make a half matter suture to produce a deep.
Half matter suture. What is half matter suture?
So we take 1 bite along
Take the bite on the skin, and second bite on the soft tissue of the trachea without going inside on the wall of the trachea. Next bite on the skin, and then make the sutures. What is the idea when you make these sutures?
Stomach. It will not produce cicatricial. I mean,
The skin should be close to the tracheal mucosa, and there should not be any soft tissue. If there is soft tissue in between these two areas, it will go for stenosis. Okay, to prevent tracheal stenosis, you have to keep the bite in such a way that the tracheal mucosa and the skin should be very close to each other. So you do these bites and then make the tracheostomy. Okay. So what are all the suspected post-operative, immediate post-op complications?
Sir, in post-op day 0, we immediate post-op intraoperatively and immediate post-op. Intraoperatively, we look for whether there is hypovolemia and excess amount of blood loss and hemorrhage. Hemorrhage should be anticipated, and so they can.
Okay, if the patient is fine, you take the patient to the post-operative ward. Okay, the patient's pulse rate is 40, BP is fine, bilateral air entry is good, saturation is fine. What do you think of? Take ECG, it's a sinus bradycardia.
Hypokalemia is there.
What?
Sir, ECG is normal, sir.
ECG is normal ECG. Sinus bradycardia. So commonest cause for sinus bradycardia in the post-operative period is you don't reverse the patient properly. You don't give a proper, if you give only neostigmine with an inadequate dose of atropine, you will get this situation, right? So what are all the electrolytes you are worried about in the immediate post-op?
Post-op day 0 and 1, we should be looking for hypokalemia and
Hypokalemia. Okay. What is the ECG change of hypokalemia?
UVA, sir.
UVA. Okay. You should look for UVA in the ECG monitor, and then you should look for the rate. There's a bradycardia, or there is a long intervals and the presence of UVA. You should think of hypovolemia. Okay. What is inappropriate secretion of ADH? How it will manifest?
Sir, any head and neck surgery can produce the complication of syndrome of inappropriate antidiuretic hormone because of stress-related injury where ADH is secreted like.
What will the patient present with?
The patient will have diuresis and hyponatremia and confusion with.
Inappropriate secretion of ADH can cause hyponatremia or it can cause edema. Okay, so you got to weigh the patient immediate post-operatively. If there is a more than 10% of weight gain in the patient, you should always think of edema. Edema is setting in. Okay, then you got to do a continuous ECG, the monitor, and then watch for cardiac status. Okay, all these major head and neck surgeries can the patient precipitate a CAD patient into a frank disease. So you got to keep that in your mind. So if next post-op day you see the drain is not working and the flap is got lifted up, what does that mean?
It is a very large hematoma that is obstructing the drain and causing the flap to bulge. So we should evacuate.
What will happen to the flap then?
If this will cut off the blood supply of the flap, which will go for flap necrosis and wound incidence.
How will you diagnose flap necrosis?
In early stages, it will have erythema and pale skin over the flap. And later stages, it will and loss of sensation over the flap. At later stages, it will go for a bluish discoloration followed by gaping of the wounds.
What else you will check for? What you check for? Sensation?
Yes, sir.
You should look for sensation on the flap. Okay. When you start the orals, suddenly there is increase in the drain. Particularly when you do a neck dissection for the patient. For this patient, left side, if you do a neck dissection on the left side, suddenly there is increase in the drain. What do you suspect?
We suspect a chyle leak, sir.
Chyle leak. What will be the color of chyle?
It will be a very whitish cloudy discharge, which will have increase in triglyceride content and chylomicrons will be high. So we have to look whether it's high output or low output.
If it's a low output leak, what will you do? If it's an high output leak, what will you do?
If it's a low output leak, we'll stop the oral intake and we'll change for TPN. If it's a high output leak, we should open like we should plan for opening up and
Look for the chyle duct and ligate. Okay, so if it is a low output leak, you should take the nutritional status, stop oral intake, and give pressure pressure dressings. Okay, this is okay. You think doing total laryngectomy is sufficient for this patient? Only total laryngectomy?
post-operative
Patient has got a node. What else do you do? Total laryngectomy with?
modified radical neck dissection.
Which one you will do first? Total laryngectomy or radical neck dissection?
First, modified radical neck dissection.
Okay. When you remove all the nodes, okay, what will you do to the nodes? Will you take it out separately or take it along with the tumor?
So we'll release following neck dissection. We should make sure it is attached to the thyroid membrane, and we should deliver it along with the larynx, not separate.
So you remove with the neck dissection, you dissect the superior part of the posterior triangle node, lift the accessory nerve, bring it under that, come to the lower part, remove the inferior aspect of the posterior triangle node, lift the sternocleidomastoid muscle from the anterior border of sternocleidomastoid, strip the deep fascia from the inner surface of the sternocleidomastoid, bring in continuation with all these nodes, and bring these nodes anteriorly, remove the level 2 to 1B nodes, 3 and 4 from lower lobe, comes everything with the pedicle attached to the thyroid membrane. You do the neck dissection. Okay, once you have finished the neck dissection, along with the neck dissection, you got to take. It is not possible always, even if there is a level 2B node, may not come along with that level 2A and other nodes. But as much as possible, you try to take everything in total. Okay, so when will you remove the sutures?
On post-op 7, we'll remove alternate sutures, and post-op
Sutures?
post-op 10, we'll remove the rectus.
Okay, when will you start the orals?
Post-op day 14, we can start oral.
10th day, you'll start orals if everything is fine. Okay, how will you identify leak?
Sir, if pharyngeal leak is there, we can see it will cause, it will have, there will be the crank saliva that is coming out of the leak site.
When you start the orals, you got to give the colored fluids like
Milk or
not Pepsi, Coke, you should give milk. Okay, so you give milk and look for a streak of white fluid coming out inside the around the tracheostome, on the sides or over the trachea. Okay, so fine. If everything is fine, how will you follow up this patient? How will you follow up this patient?
Sir, we'll
Ask the patient to come after, say, 3 months. Patient is coming back. What will you do?
now we can plan for a secondary TEP, sir, or
3 months afterwards.
we'll do a PET CT, sir.
PET CT. What are all things you look for? You take an X-ray chest.
Yes, sir. X-ray chest.
You take an X-ray chest. Then you do an abdominal ultrasound. Or you do an abdominal ultrasound. Then you do a T3, T4 for TSH to see whether the thyroid function is normal. Then you do a video laryngoscopic examination. Okay. So with all these things, so every 3 months the patient should come for the first 2 years, or first year should undergo all these things. And second year, from second year onwards, every 6 months that patient should come till 5 years. What do you think the 5-year survival rate of this patient?
Since it's a glottic tumor, it has got 77% survival rate, 5-year survival.
And there is no nodes.
Node, when there is no node, will decrease the survival rate by 5%. So 77.
Whenever there's a node is possible, the survival rate will drop down 1/3. So this patient 5-year survival rate is 45%. What other modality you give to increase the survival of this patient?
Post-operative RT can be planned.
When will you start RT? After 6 weeks. Okay. What will you give?
We can
Post-operative RT, how many doses? How long you'll give?
give a 50 to 60 gray of post-operative RT in
Okay.
fractions, 2 gray per fraction, 5 fractions per week for 3 weeks.
Why 2 days leave?
Because this cell cycle, this will allow the
This is for the all the active cells to get remission. Okay, so that all the dead cells will get cleared off, and all the other active cells will come into view. Okay, so you give 5 to 6 weeks of post-operative RT. Why don't you give a pre-operative RT? You could have given a pre-operative RT.
you can plan for a pre-operative RT as an induction chemotherapy and look for responders. And
which is better, induction chemotherapy or concurrent chemotherapy?
induction chemotherapy, sir.
Why?
Sir, we give 3 cycles of induction chemotherapy, and then look for responders and non-responders. If responders, then we can go for, if it becomes very organ.
RTOG 9111 group will tell you that you have 2 arms or 3 arms. Okay, 2 arms is the one you give a anterior chemotherapy, otherwise called induction chemotherapy. Induction chemotherapy, you give a 5-fluorouracil and cisplatin. Okay, you give them 2 cycles. On the third cycle, you take the call. See whether they are responders or non-responders. If they are responders, continuous chemo. If you are non-responders, go for surgery. Okay, if you want to do surgery, what is the ideal surgery you do for this patient? If there is no neck nodes.
If there is no neck nodes, supracricoid partial with
Supracricoid partial laryngectomy with
cricoid.
the patient has got a subglottic extension and a cricoid involvement.
Near total laryngectomy.
What is near total laryngectomy?
So the Pearson's concept of near total laryngectomy is done for lateralized tumors T3 T4 where there is no involvement of the inter-arachnoid or retroarachnoid region. So in this case, it is possible, like near total laryngectomy is possible. Since it's a lateralized tumor.
To do a near total laryngectomy, you need one cricoid unit. You need one intact, non-involved arachnoid joint, area epiglottic fold, along with it, its blood supply, its nerve supply. If you could preserve that, you make a mucosalized shunt in the mucosalized shunt in the pharynx, so that the patient can use this as for voice. Okay, if that is so, which is better, conservative surgery of larynx or near total laryngectomy?
Surgeries preserve both nasal respiration and voice, whereas near total they preserve only voice. Respiration is bypassed. So with respect to voice, conservative surgeries, sir, with respect to voice, conservative surgeries are better because it will preserve both nasal respiration and voice, sir. Whereas near total laryngectomy will preserve only the voice and nasal respiration is lost. So with respect to voice conservation,
What is conservative surgery of the larynx?
Open partial laryngectomy surgeries for
Conservative surgery of the larynx is defined as a surgery by which you give the cancer clearance
okay.
with keeping in your mind that you do a complete cancer clearance with normal swallow, adequate airway, and serviceable voice. You are not expected to sing.
Okay.
You are not expected to give big speeches. That's called serviceable voice. But it's a voice is enough to communicate. Then you have an adequate airway. The airway is not sufficient for the patient to go and do his marathon unless they slowly train for that. Okay, what they can do is they can do an adequate day-to-day life, and then you should have a normal swallow. If if you do all these three things, it's called a that's called the conservative surgery of the larynx. Okay, so what is TLM?
Transoral laser excision or a transoral laser microsurgery can be done for T1, T2 lesions of the
Transoral laser microsurgery is what modality of treatment? Surgical modality, endolaryngeal, or what?
Sir, they are endolaryngeal modalities. Sir.
Transoral laser microsurgery is not one modality alone. You can give a post-operative RT. You can give a open surgery if you have a mobile neck node and want to do a radical neck resection, and you do a endolaryngeal surgery for the primary tumor. Okay, that is transoral laser microsurgery. You can do a transoral laser microsurgery for this patient, or you can do a suprachiasmatic laryngectomy with ioepiglottoplexy, or you can do a cricoiodopexy. Okay, any one of these two you can do. Okay, if the anterior commissure is involved, all three layers as well, what is the preferred modality of treatment? What partial surgery you will do?
We can go for vertical partial laryngectomy.
What surgery is that?
Sir?
What surgery is that?
Vertical partial, the Billroth's concept of vertical partial.
Frontolateral partial laryngectomy. Do a frontolateral partial laryngectomy. You involve the anterior commissure and unilateral resection of these tumors. Okay. Will you think you will do it in your center?
In a center, total laryngectomy.
Laryngectomy is the choice. Okay. Then if your patient is not willing for total laryngectomy, you want to preserve the voice, what surgery? What is your option?
Then you can go for chemo RT, sir.
Chemo RT. Okay. What are all the chemotherapeutic agents we use?
In either by veteran trial, we can either a 2-drug regimen or you can use a 3-drug regimen. If it's a 2-drug regimen, we can go for cisplatin and 5-fluorouracil. If it's a 3-drug regimen, along with it, taxane docetaxel or paclitaxel can be used.
Paclitaxel or docetaxel can be used. Okay. So how much is the dose of cisplatin?
So cisplatin, the dose is 75 to 100 milligram per meter square. That is given on day 1, 22, and 43. It is given 3 weekly once, sir, which acts by inhibiting DNA synthesis and also decreases the hypoxia-mediated damage, so which increases the radio sensitivity.
What are all the radio sensitizers?
So there are two types of radiosensitizers, true sensitizers and apparent sensitizers. True sensitizers do not have any cytotoxic effect. This include including carbazine or hyperbaric oxygen or erythropoietin can be given. Whereas apparent sensitizer, we can give glutathione synthase inhibitors, because this will decrease. Glutathione is a radio protection. So when we give the inhibitors so that the radio sensitivity increases. We can also give antihelminthics like nitronamidazole or ornikezole, etc. And we can give the
Levomizole.
misoconazole.
Levomizole.
Uh,
Levomizole. Then
we can give nicotinamide, sir, and we can also give purine or pyrimidine inhibitors.
your chemotherapy itself is a radiosensitizer. Giving a radiotherapy alone along with that chemotherapy, the simple things you don't advise, like the blood transfusion or blood transfusion, anemia treatment, all these things will or the radiosensitizer. What are all the drawbacks of pre-operative or pre-chemo, primary chemotherapy?
Primary chemo will
there are two, three things. One is the patient psychology. Okay, when you operate and take out the tumor, patient feels that the tumor has gone out of the body. But if you give a chemotherapy or radiotherapy, that's a prolonged period, which is elder people, which will they will withstand better. Surgery or chemotherapy?
surgery, they will withstand.
Elderly people, even though they have other that age is on the wrong time, wrong side, they will withstand surgery better than chemotherapy, because surgery finishes in 2 weeks, 2 weeks, 3 weeks time when you do it properly. But chemotherapy, it prolongs for 6 weeks. And what are all the radiation radiation reactions?
You can produce skin changes like stomatitis and mucositis, and mucosal involvement called mucositis. With respect to ear, it can produce otitis media, or it can produce sensory neural hearing loss. With respect to nose, it can cause temporary loss of anosmia, and with respect to
You want to go above anosmia and all.
it can produce osteoradionecrosis of the temporal bone
Mandible.
of the mandible.
Okay. So how many portals they'll give? What's an anterior portal? What is lateral portal?
They use 3, 4.
Anterior portal is for the larynx, and the lateral portal, they will shield the brain and the vertebral column for the neck nodes. Okay. So you will get mucositis, dysphagia. Patient will not. Patient will have a dry mouth. How will you manage dry mouth? How will you clean the oral cavity? If there is a dry mouth, what treatment you will give?
We can give xylogogues to increase the production of saliva.
If there is no the gland function itself, how these xylogogues work? If it's not working, what will you give? What is artificial saliva? Like artificial tears, you can give artificial saliva. Okay, you make small balls of small balls of the things which will increase salivations. Like we use tamarind. Take tamarins, make it into a small balls, keep it under your tongue. Or you can take the what do you call that? Orange toffees or lemon toffees. Make it, break it into a small pieces, and they can keep it under the tongue. Okay, that will increase the salivation. Okay, so what are all the okay? The other drawbacks are all it will produce edema, laryngeal edema. You are going to give radio chemotherapy because you want to do a organ preservation. Okay, but the problem with an organ preservation is that the problem with an organ preservation is that it's not always you can preserve the organ. So when there's the tumor with the focal cord fixation might require tracheostomy, because if you give a chemotherapy, the patient can develop edema. Okay, so patient can develop edema, or patient will not patients develop dysphonia because of the radiation-induced scarring of the vocal cord. Patient develops dysphonia. Okay, then patient can have a dysphagia. Chemotherapy produces severe pharyngeal stenosis. Okay, so patient can have dysphagia. If the patient has got a persistent pain and persistent edema, what do you suspect?
Patient, it means that patient has got perichondritis of the
Larynx is fine. Inside, you see the edema. You do a indirect laryngoscope examination, you see that edematous area epiglottic fold, edematous arytenoids, edematous ventricular bands. What does that mean? What do you suspect?
radiation induced
Recurrence, or maybe a residual tumor. It's very difficult to diagnose a residual tumor because residual tumor you will have a residual tumor. You got to find the tumor and take biopsies. In spite of all these edema, you should make the diagnosis. If it is possible, if it is positive, what will you do?
We'll take a 4-quadrant biopsy, and if it is a positive, it's a recurrent. If it's a recurrent growth, we can go only for salvage surgery. Salvage laryngectomy, salvage total laryngectomy.
Salvage total laryngectomy. Okay, so okay, how will you what is radical neck dissection?
So radical neck dissection, we include all the 3 non-lymphatic structures like sternocleidomastoid, accessory nerve, and IJV is sacrificed, and this is done for N2B and N3 nodes, which are in very close proximity with the IJV. Or radio recurrent nodes, or very large nodes. However, it is
What are the contraindications for radical neck dissection?
when there is a very
There are 3 contraindications, absolute contraindications. One is node adherent to the
carotid
vertebral muscles. Second is node adherent to the
great vessels, sir. Great vessels like carotid.
brachial plexus. Third one is node adherent to the skull base. These 2 are the absolute contraindications to a neck dissection. Even if there is a carotid is involved, you can sacrifice carotid and put a graft. Okay, so what will happen if you remove the sternomastoid?
Sternocleidomastoid, it will cause only cosmetic deformity, sir, not much.
Okay, what will happen if you do if you remove the accessory nerve?
If we remove the accessory nerve, it can cause frozen shoulder or drooping of the shoulder. So we have to manage it with physiotherapy or intra-articulate glutathione injections.
Okay, how will you manage? What will happen if you remove the intrajugular?
If we remove one side IJV, it increases the intracranial pressure by 2 folds. If both the sides is removed, it increases the intracranial pressure by 5 folds, which will cause facial puffiness, edema, and
Headache, brain edema.
headache.
Okay, so how do you prevent all these things?
With respect to IJ, prevent.
If you want to retain, what surgery you do?
You can go for a modified radical neck dissection, either type 1 or 2, type 1, 2, or 3. In type 1, we preserve the spinal accessory nerve. Type 2, we preserve the spinal accessory and the IJV. Type 3 or functional neck dissection becomes where spinal accessory, IJV, and sternocleidomastoid mastoid is preserved.
Okay, what is it called?
Functional neck dissection.
Functional neck dissection. Okay, so so this is only on the lateral neck for the 1B, 2, 3, 4, 5. Okay, but all the cases you should do the central compartment dissection. Okay, what are all the complications of total anatomy? Late complications.
Late complications can be stomal stenosis, perineocutaneous fistula, or patient can stomal stenosis can be either circumferential or lateral shelf stenosis. Pharyngeocutaneous fistula can occur, and hypothyroidism can occur, and patient can present with stomal recurrence.
Patient presents with stomal recurrence. What are the types of Sisson's classification?
According to Sisson, there is clinical and CT based staging. If it is clinical based staging, there is there are 4 stages where 1 and 2 is suprastomal recurrence, 1 without and 2 with esophageal involvement. 3 and 4 is infrastomal involvement, with 3 with the involvement of mediastinum and 4 with the involvement of the clavicle.
Great results.
Great results. So this
subclavian, archaeophyta, things like that.
Yes.
Okay, how will you manage?
Sisson's grade, all grades are managed only surgically, sir. If it is 1 and 2, we'll go for cervical esophagectomy is done, and 3 and 4 upper mediastinum is with the help of a cardiothoracic vascular surgeon. The superior mediastinum is thoracotomy is done. Mediastinum is opened, and we look for the obvious mets. I mean obvious recurrent mets, and we take it out along with clavicle partial resection of the clavicle, medial half of the clavicle.
Partial resection of mediastinum and the medial end of the clavicle, and do a mediastinal tracheostomy. Okay, how will you manage pharyngeocutaneous fistula?
If it is a low output fistula, we can wait. We can go for conservative management. However, if it is it is presenting with signs like increased redness or increased amount of leak or skin changes is there, then we have to we have to do a CT fistulogram and look for the extent of the tract, and then we have to excise. We can go for a flap cover, sir. Delta pectoral.
What will you give, flap cover or lining?
Flap cover.
Cover means what you put here.
Okay.
Lining is what you put inside like this. You're going to give lining and cover. What usually for a axial flap, what is the lining? What is the cover? Simple lining and cover. What flap you use? For lining, you do a pec major flap. For cover, flap. Okay, what is pectoralis major flap is?
It's a.
When you do for your patient, if there is a defect, what's an advantage of doing a pectoralis major flap? When you are doing a neck dissection, what is the advantage of pectoralis major flap?
Better cough.
You put a pectoralis major flap. If you do a excision of sternocleidomastoid muscle, your carotid will get exposed. So you put a flap, myocutaneous flap that will cover the sternocleidomastoid. The chances for carotid blowout, even if it's get infected, is lesser. Okay, so the pectoralis major is a myocutaneous flap. What is the flap we use for the cover? It's called deltopectoral flap. Deltopectoral flap is the faciocutaneous flap. Okay, so what is Janus flap? What is Janus flap? In Greek mythology, there's a god called Janus. It's called,
Lactosmic dorsal flap.
It's got two faces. You have one face in the front, one face is behind. So you take a myocutaneous flap, stitch a skin graft to another side to give a lining and cover with a single flap. That's called Janus flap. Now we don't use those flaps. You can use a skin flap. That skin flap is called Wookie's flap. Then you can close the percutaneous fistula by a bucket handle technique. These are all the various older flaps used for percutaneous fistula. Now you want to close it. What do you close it with?
Pec major flap.
It's bulkier. Want nice soft. What's the drawback of pectoralis major flap?
Costness.
For females, it involves there is a breast on top of that. You can't take the lot of skin. For males, you have air containing part. The skin will be inside the pharynx. So sometimes air, if it grows, you got to look inside the oral cavity to take care of that skin. Okay, and the skin will usually go for stenosis. So patient will go for pharyngeal stitches are very common with the cutaneous flaps. Okay, if you don't want stenosis, you want a nice soft succulent flap, you got to give a mucosal flaps or a lateral thigh flap or a radial forearm flap. If you want to do a mucosal flap, what mucosal flap will do?
Pre-jejunal flap or
Pre-jejunal flap use as a sheet, not a lumen. If you do a total pharyngectomy, you can keep the same flap as a lumen loop. But here you cut the antimesenteric border, take it as a sheet and for the lining. Okay, fine. How will you rehabilitate the patients post-operatively? What are all things you will take? What are the drawbacks this patient will have? Total pharyngectomist patient.
Patient preoperatively, we have to sensitize the patient that patient will not have speech, normal speech, and patient cannot go for swimming or normal, even taking bath, head bath.
Sternus exercises. Sternus exercises. Okay. Patient can't do very sternus exercises like pushing, pulling, weight lifting, driving lorries or heavy duty vehicles, or the sternus exercises, it requires fixation of the chest will be little difficult. Okay, can this patient go for swimming?
It will lead to aspiration, sir. So patient cannot go for.
Patient cannot go for swimming with the normal tracheostome or tracheostomic tube. Okay, you can fit in something like a snorkeling, a tube which will come out, and then you can go for swimming if you want. Okay, you are like a hands-free speaking valves. You can use that. So how you rehabilitate post-laryngectomy patient's voice?
We can go for secondary tracheoesophageal processes. Either we can, if the patient is well aware and educated patient, we can go for esophageal speech, which should be started even pre-operatively as early, like so that patient we can sensitize the patient. Or post-operatively, we can plan for secondary TEP or artificial larynx.
Patient doesn't want secondary TEP. Patient is not getting esophageal voice. What do you do?
We can go for an artificial larynx like pneumatic larynx.
Or to be electronic larynx.
Electronic larynx.
Okay, you can use artificial larynx or electronic larynx. Okay. What else you will see? I mean, what is primary TEP? What is secondary TEP?
Primary TEP is done intraoperatively following cricopharyngectomy, and the difference is that if it's a primary TEP, it is done at 5 to 8 mm above the level of the upper edge of the tracheostoma. If it is a secondary TEP, it is done at about 6 to 10 mm above the level of the tracheostoma. And the primary TEP has got a better prognostic, like with respect to voice, because the patient is if it's a secondary TEP patient, the
Stenosis can occur, and the chances for better voice is lesser. Okay. 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 What is the processes which is used there?
We can use duckbill prosthesis for secondary TEP, or we can use a Blom-Singer prosthesis if for primary TEP.
Okay, what are the complications of these processes?
If it is a non-speaking valve, it is mostly due to the granulations around it, or if it is a non-speaking with excessive leak, then we have to look whether see whether there's pistoning effect, or with it's a widened. When
do you change this valve? When do you change this valves?
Sir, there are two types: indwelling or exdwelling valves. Indwelling valves we don't have to change. Exdwelling valves can be changed by the patient.
What if it develops fungus?
Yes, so then most commonly it can go for infection by fungal infection. In that case, we have to remove it and clean it in cetrimide solution and
use another valve. Come on, use another valve. Buy another valve and use it. Okay. All the problems will come, only the patient can't afford. Now you have an Indian valve which is not very costly, even about 600 rupees you get the TEP valve. So okay, where will you get artificial larynx?
Artificial larynx is reserved for all the cases where failure has occurred, like whether it's a esophageal speech or
What's the drawback of artificial larynx?
It produces a very monotonous, robotic kind of voice, which is unpleasant to hear.
That is style only, no?
Sir?
That's a style, no? Okay, it occupies one hand, right? Usually you got to keep your larynx like this, or even if you place it, it involves extra effort. Okay, while the esophageal voice, you can talk without what do you say? Esophageal voice, you can talk straight. Okay, what are all the patient can develop dysphagia? How will you manage dysphagia?
The patient presents with dysphagia, we can go for we can go for a peg or
what to take what is dysphagia?
Difficulty passage of food bolus from the mouth to the stomach.
It's a defect in the transportation of the nutrients and the oral secretions. Every day you will secrete about 1,500 ml of saliva, which is rich in sodium, potassium, and a lot of enzymes. So you can't lose all those things. For PEG, you will lose all these things. It's not going to work that way. So you got to find out why the patient developed dysphagia. Dysphagia may be because of post-RT or post-surgical stenosis of the foot passage. What will you do then?
If it's because of a if it's because of a spasm, we can go for cricopharyngeal Botox injection. If it is because of stenosis, then we have to do serial dilatations so that the sphincter, serial dilatations can be done. If that has also failed, then we can go for a gastrostomy or jejunostomy. If patient is not willing for that, we can go for a PEG or reg.
Stent. Two individual stents.
Okay, sir.
What is Souter's tube? What is Atkinson's tube?
There are esophageal stents which can be used for chronic aspiration, which works by the mechanism that.
Chronic aspiration. How do you get aspiration? You are done a end tracheostomy. There is no forgivability in the slab. Where's the question of aspiration? Stenosis, release that stenosis, put a stent so that it will not get closed. Okay. So fine. What is the prognosis of this patient?
The 5-year survival rate is 77% for glottic tumor because it is has got nodal involvement. It is reduced by 1/3, so 45% will be the
prognostic factors. Okay, right, fine. Anything else? Deepak?
Sir,
I think almost we have come to the fag end of the presentation.
next. Next class, sir.
Next week we'll have on thyroid and parotid.
Okay, sir.
Okay.
Okay.
We'll try to have a thyroid tumor.
Okay, sir.
Okay, and parotid. Actually, thyroid is the vast, bigger than the larynx. But the problem is, we'll discuss that as a short case. So I don't know how much you talk about thyroid is required for MSPGs, particularly for a differentiated carcinoma. What are the prognostic factors? How do you check up the prognostic factors? How do you do that surgery? What will you do when there is a less than 1 centimeter tumor, or what is the treatment for medullary carcinoma and anaplastic carcinoma? It's all we'll try to catch one solitary nodule there and try to discuss it in one general clinics. Okay. So
Yes,
thank you everyone. Thank you for your patient listening, and congratulations, Jenny. You are bold in spite of all this barrage of questions.
I would like to take this opportunity to thank you for the mentor you are, sir. Thank you so much.
Welcome. I'll thank Janagiram, Deepak, Pula sister, Sivasubramaniam, and the big boss Satya. Okay. Thank you everyone. See you in
Thank you so much, sir. Thank you so much for the elaborating session.
See you, Deepak.
Thank you, sir.
Thank you.
Thank
Right. We'll see you in that next Grand House.
Thank you, sir.
Thank you.